Hi everyone, this is Graham Short. I'm with the Washington State Medical Association. Just wanted to start real quick and let you know that we're going to give everyone a couple minutes to get on the webinar. So just hold tight and we'll begin in a couple minutes. For those of you who've just hopped on, we're going to just wait a minute or so to let enough people get on before we start, so just hold tight. Okay, good afternoon, everyone. My name is Graham. I'm with the Washington State Medical Association, and I'd like to welcome you to our 2016 Legislative Wrap-Up webinar. First, thank you all for taking time out of your busy day to attend this webinar. We know your time is very valuable, and we hope the information you receive today will in turn be of value to you. Before we start the program, a few technical notes. All attendee lines are currently muted. This is to ensure the integrity of our audio. We very much encourage that you ask questions. If you have any questions for our presenters, please submit them via the control panel on the right of your screen. The presenters will be responding to your questions at the end of their presentation. If you encounter any problems with the connection to the webinar, please call our Seattle office at 206-441-9762 and ask for Michelle. Again, call the Seattle office 206-441-9762 and ask for Michelle. And finally, thank you for your continued support of the Washington State Medical Association. As you all know, membership is vital for us to remain an effective voice in Olympia, so thank you. And without further ado, our presenters today are Katie Kolan and Sean Graham, who many of you know, and who head up our Fearless Advocacy team in Olympia. So here is Katie and Sean.
Hey Graham, thank you so much for handing the baton off to us. As Graham said, this is Katie Kolan, Director of Legislative and Regulatory Affairs.
And Sean Graham, Associate Director of Policy and Political Affairs.
We're really lucky to have you on the line. This is our third annual legislative session update webinar. We're really excited to have you. A little bit of housekeeping on this side. You are not going to get a preview of every single bill that the Washington State Medical Association put their fingers on this year. But what we've done is we've really selected for you what rose to the top for us. So not only the policy bills that were important to us, but also those budget items that are really at the top of our to-do and the top of our must-accomplish this legislative session. So before we dive in, we'll be going through a bit of legislative context to get oriented to where we're at in the legislative process. We'll dive in a little bit into the budget, remembering that this is a supplemental budget year, not the operating budget year. And lastly, we'll dive into the top five, essentially the top 5 policy concepts that we'd like you to take away from this presentation. And certainly at the end, there are nuggets at the end we want you to stick around for, where we'll address elections, upcoming elections and campaigns, and basically how you can stay involved in the legislative and advocacy process down in Olympia.
And guys, we've highlighted what we think are the main areas of focus from this legislative session, but we know that you might have bills or issues that you're particularly interested in. Please do utilize the question option, and we will address those as best we can at the end of the webinar.
And in the event we don't get to your question, you will find our contact information at the end of this presentation. So please feel free to email either of us, and we'd be glad to attempt to answer your questions. Okay, let's get oriented to legislative session. So you might think that we have concluded the legislative session, and we did conclude the original legislative session, but we are now in what's called a special session. So what does that mean? It means essentially anything that can be done in a legislative session essentially can be done in a special session. The legislature failed to come to a budget agreement in time for the session to adjourn by March 10th. So what we're in right now is again a special session in the hopes that the legislature will come to a budget agreement, and we'll dive into those budget details shortly. This webinar, as I said, is a preview. So what you're seeing now is not fully baked because the legislature has not yet adjourned. So we'll go through some of those pieces of legislation that are still in the works, still in process, keeping in mind that really it ain't over until it's over. You also should keep in mind that the Washington State Medical Association will be sharing with you a legislative wrap-up, which will give a comprehensive overview of the bills that we addressed. Again, this webinar will not address everything. And importantly, for your practice operations, we will be also sharing a publication that is practice impact guidance. So really an impact on the ground for your practice and the operation and the practice of medicine with regard to the legislation that passed this year.
So Katie mentioned we won't be hitting on everything that was addressed this year, and there's a reason for that. There were too many things that we would have to hit on. You'll see on this slide there were almost 1,400 bills introduced just in the 2016 legislative session. It's a 60-day session. It's quite a few. I think it's about 25-ish bills per day. Sorry, that's Central Washington University math, folks. But what's important to keep in mind is two things here. One, the vast majority of those bills were introduced in the first couple of weeks. I mean, we were seeing hundreds of bills each day that we were having to pour through and figure out what the ramifications of those were. But in addition, Katie mentioned that this is a 2-year legislative cycle. So last year was 2015 was the first year. Anything that didn't pass in 2015 carried over to 2016 and was automatically viable in 2016. So there was a ton of bills that were just hanging out there from 2015 as well. There were 200 bills in the healthcare committees alone this year, and it's a large number of bills to work through on a tight timeline. And you'll see there the bills passed by the legislature, almost 300. It's a high passage rate, and there figured to be more once the budget agreement is reached. Not only will the budget bill itself have to be passed, but there's any number of bills that are associated with the budget that would pass as well. So that number will go up, and that is historically a fairly high watermark as far as bills passed, particularly in a shorter legislative session.
Yeah, so if you take a look at the right-hand side of this slide, you can see that there are questions that still remain. Sean hit on that NTIB, those bills that are necessary to implement the budget. For example, we've got a few pieces of vaping or e-cigarette legislation that are necessary to implement the budget because they will impact the operations of the state budget in some form or fashion. And again, that information has yet to be determined. So remember, those bills that are NTIB are still alive and being contemplated. So let's move on to the second bullet, governor vetoes. Why are we addressing governor vetoes? So the long story short here is because the legislature, the governor's office argued that because the legislature failed to come to a budget agreement by the end of the regular session, the governor threatened to veto legislation. So,
and the idea was there, from the governor's standpoint, the budget is our primary focus in a supplemental budget year. That's the main thing the legislature should be addressing. So until the budget is addressed, everything else is subsidiary. And those bills that are subsidiary, some of them, in his wisdom, he chose to veto in hopes that the focus would be put back immediately on the budget.
Sean is describing that fairly favorably. The reaction, I would say, generally has been disfavorable to the, specifically to the governor's vetoes, knowing that number one, it didn't actually force a budget agreement, and now the secondary effect being that good bills were killed. So what we're looking at here is no priority WSMA bills were harmed in this first veto. We will be considering a call to action for this body for the Washington State Medical Association membership should we get word that the governor is considering another wave of vetoes. That being said, we wanted to speak just briefly to a couple of the healthcare bills that were vetoed. You'll see Senate Bill 6569 addressing patient out-of-pocket costs with regard to pharmaceutical pricing. If you actually take a look at this bill, it's a pretty high-level task force bill. So the task force would include patient groups, insurance carriers, pharmaceutical companies, prescribers, pharmacists, etc., to sit around the room and discuss how we can figure out how to address pharmaceutical pricing. The second bill that was vetoed that we have interest in is Senate Bill 5145. This is one of those bills that Sean mentioned earlier, was alive from the 2015 legislative session and was actually one of the first bills to arrive to the governor's desk, hence the veto. This bill simply put a clinical non-voting expert on the Health Technology Assessment Committee. The idea being that if the HTA is going to review, let's say, a urological type technology, we should probably have a urologist on that committee.
So 37 bills were delivered to the governor during session. Of those, he vetoed 27 and signed 10 into law. The next date, and this is important, the next date to keep in mind, folks, April 2nd is the date by which all of those other bills that were delivered to the governor, he will have to take action on. If he signs them, they go into law. If he just does nothing, there's no pocket veto. So if he does nothing, the bills go into law. If he vetoes them, obviously that would create some problems with regard to, in particular, our priority legislation.
Thank you. So we're going to move on now to the budget. I want you guys to get reoriented now. We gave you a big high-level session context. So what we're going to be looking at now is the budget.
And again, we're working off of, this is a supplemental budget year. The legislature in 2015 wrote a 2-year state budget. So what the short session that follows is designed to do is to make tweaks as necessary. Maybe more people are moving to the state than anticipated. Maybe people are spending more or less than anticipated, and the budget needs to be adjusted accordingly. So last year's budget, about a $38 billion budget. You see more investments in K-12 spending pursuant to that McCleary decision, which said the state isn't doing enough to support basic education. You also saw college tuition decreases. This is something historic, and I know for folks who have college-age kids, something that people are pretty excited about. And you saw some great investments in mental health pursuant to another Supreme Court decision. More investments needed there as well as in education. So coming into 2016, we knew that more investments were going to need to be made in both education and mental health. We also found out in November that revenue was not at the mark that was expected. The state is still, like, we're coming out of this great recession, and I think by and large things have stabilized, but it hasn't been the kind of recovery that would generally accompany a recession. So revenues are up, but fairly stagnant. And then in November, what we found out were that caseload costs were higher than anticipated. A lot of that driven by the healthcare authority, and depending on who you ask, if you ask the healthcare authority, they would say drug pricing. Some folks would say there may be other elements in there as well. The bottom line is that there's a lot of unforeseen costs around Medicaid that made writing a supplemental budget more difficult.
Okay, so thank you, Sean, for going through the sort of high-level budget picture. Let's dive in a bit to what we were contemplating this year in 2016, and then we'll describe for you what we've actually seen in the budgets released from the House and the Senate. So top priority, protect the Washington State Medical Association investments that we secured last year. So you can see the couple bullets there, and those of you who are familiar with our work, you should be familiar enough with these concepts. Student loan repayment. So for example, last year we secured $9.6 million for health professional student loan repayment, specifically those who are working in family practice and out in priority 2 rural areas. On the graduate medical education front, you can see that we secured $32 million in the form of medical residencies. So we wanted to make sure, at a minimum, when we're going into the legislative session in the supplemental budget year, that those monies are undisturbed.
And the reason that's important, there's a tendency among the legislature called last in, first out. When the legislature is presented with a difficult budget situation, they have a tendency to swipe back the monies that were most recently allocated. And the reasoning there would be that maybe those investments haven't really had an opportunity to take hold. Maybe you can take that money with making less of an effect than you would with other programs. So we were really keying in on this coming into session.
Quite. You can see the second bullet, no taxes directed at physicians. That one should be pretty self-explanatory. The rest of these are a little bit more detailed. Pediatric Medicaid funding. So the Medical Association has, for the last couple of years, sought to increase Medicaid reimbursement rates, especially after the big wave of Medicaid expansion that Washington State undertook. In the past, we had requested full Medicaid reimbursement for all practitioners across the board, addressing primary care. We narrowed that focus a bit this year to Medicaid reimbursement, Medicaid funding specific to pediatric care. The thinking there was $7 million is a lot more doable than $36 million, or let's say $100 million, as we had asked for in the past. Mental health student loan repayment, $3 million. Again, we're building off of the student loan repayment success from last year. We're looking specifically for $3 million above that 9.6 to address student loan repayment specifically for mental health care practice area. With regard to the vaccine portal and module, what you see there is $511,000. That is $511,000 that would go to build out the school side vaccine portal or module. So when a physician is entering a patient's vaccine information, that information would be transmitted to the school in an easy to read and an electronic format so that schools aren't reconciling those student records on the back end. Ultimately, the goal there is our attempt and the Department of Health's attempt to increase the vaccine take-up and compliance rate in schools.
And those of you who've been following our correspondence or following our testimony during session, you'll note that we haven't been talking about this one a lot. There's a reason for that. Talking about vaccines and vaccine-related issues, not always the best idea. Fortunately, we've been able to fly under the radar with this a little bit to date.
That's a great point. And lastly, and we'll address this bill in a bit more detail later, the Maternal Mortality Review Panel. This is one of those issues that is funded in the budget. It also had a policy element, so it took the form of a bill. And again, we'll describe for you in a little bit more detail in a bit what that bill covered. So let's jump into the side-by-side. As you can see, the first $7 million ask we had, pediatric primary care reimbursement through Medicaid. Neither the House nor the Senate decided to prioritize that. That was not unexpected, especially in a supplemental budget year. So again, if you have any follow-up questions, we'd be glad to give you more context on that. The vaccine module was funded at $511,000 in both the House and the Senate budgets. We're excited to see that. Again, we can't promise anything, but it's a good sign for having that $511 included in the final budget. Let's take a pause here on the health professional student loan repayment for mental health. This budget item got a little bit convoluted. We've seen several versions of budgets. So the first Senate budget proposal we saw actually had a $1 million cut to the $9.6 million we secured last year. The second version of the Senate budget restored that cut, so essentially sits at zero, avoiding a $1 million cut. The House budget on the same issue did fund those mental health student loan repayment slots to the tune of $1 million. So we're looking at a difference between 0 and $1 million on health professional student loan repayment. Now let's move on to the health professions account. So what you see here is a sweep. So what the Senate did was they took $500,000 not just from the health professions account, but from a whole swath of accounts, not just healthcare, but across industries. And $500,000 sweeps took place on those accounts, and those monies were put into the state general fund to satisfy the state's debt. What you see in parentheses on the slide is there is no physician fee increase. If you'll recall that this $500,000 sweep impacts the health professions account, all health professions, so everything from chiropractors to naturopaths to animal massage therapists to MDs, DOs, etc. And again, we've confirmed with the Department of Health that this will not result in a fee increase, a licensure fee increase for physicians. For physicians.
But broadly, this is important, and we've been very opposed to this component of the Senate budget. This is not an appropriate utilization of licensure fees, regardless of whether it would increase physician licensure fees. The funds need to stay where they're at. We've made that clear to the Senate. We're hopeful that will be reflected in the final budget.
And if this issue sounds familiar to you, we did issue a call to action on the health professions account money specifically to ensure that we're doing our best to advocate for those $500,000. And what you see on the House budget with regard to the health professions account is no sweep. Lastly, no tax increases on physicians. We were able to successfully avoid that. Okay, folks, pause here for a moment. Take a look at this slide. If you take nothing away from this presentation, and I hope you remember and hang on every word we say, we at least want you to walk away with knowledge about these 5. We'll go through the bad bills defeated. That's our favorite section. We'll hit that first. There are actually a few issues contemplated under number 5. But again, we want you to take away information on credentialing, telemedicine 2.0, medical assistant medication retrieval, maternal mortality review panel, and again, those bad bills defeated.
So starting out in the bad bill section, and starting with a big one, this is balance billing. This is an issue that those of you who have been in and around the Medical Association for a number of years will recall dating back to 2009 through 2011. It's kind of been in hibernation since then, but the OIC brought legislation this year that would prohibit balance billing. And balance billing, as we know, is the scenario where a patient presents at an in-network hospital that may have an out-of-network component within it, maybe a specialty in the emergency department, anesthesiology, radiology, etc. The specialist may bill that patient's insurance, but if they're out of network, they may get a portion of the reimbursement or none at all. That physician may then bill the patient. The OIC sees this as a problem that needs to be addressed. Based on our research, it's really not that prevalent of a practice. It happens to a small number of patients, and when it does, the bills are pretty small. The OIC's legislation really, pretty sweeping in scope, could have a lot of unintended consequences, do a lot more harm than good, in other words. What we asked was, we're open to conversations on this issue, but it needs to be clear that this is a problem before we're going to sit down and actually try to solve it. And
what Sean didn't mention, but that should be kept in mind on this particular issue, is the Washington State Medical Association has had a conversation with the legislature, is a nice way to put it, since roughly 2009 or 10, and possibly earlier than that. And as you can see in that bullet, it's highly technical issue and political. If you or your specialty society has any interest in further discussing this concept of how a prohibition on balance billing or a potential solution, I'm putting that in air quotes, if a possible solution would impact your specialty, we'd love to speak with you.
The second one on the list there, associate physicians. This is an idea brought forward by the chair of the House Healthcare and Wellness Committee, Representative Cody. She sees a problem with medical school graduates who are unable to match to a residency, and her solution is we should throw them into practice under the license of a physician. I think Representative Cody was she's coming from a good spot, trying to address a workforce shortage issue that we've spoken to the legislature frequently about. Again, though, this is a solution that probably causes more problems than it would solve. We are going to continue to work with Representative Cody, see if there is something that can be done in this way, but having them act as doctors when they have not gone through a residency, they haven't done that hands-on training, probably not a great idea.
Okay, folks, this third bullet is my favorite one, and you can see that big thumbs up. I want to put most of that attention on this third bullet, naturopath opioid prescribing. You might be familiar with this issue. We've seen this take a few different forms. We actually saw it in the form of a Sunrise review through the Department of Health, and what we've seen to the legislature is this is actually, I believe, the second attempt or third attempt to pass a bill to expand prescribing authority for a naturopath. In this case, the legislation was attempting to expand prescribing authority from Schedules 2 through 5 for controlled substances. It should be very clear that the WSMA's position on this was that of opposition. We were aggressive in our opposition. Actually, one of your colleagues, Dr. Peter Dunbar, came down to support us in testimony. We opposed this bill. The bill died. Why are we including it on here? Not only because it's fun to tell you about things that we killed, but also because we expect to see this issue come up in some form or fashion again. If we don't see it in the legislature, we may see it be addressed at the healthcare authority level. In recent years, naturopaths have been added to the Medicaid list as a billing provider for the purposes of primary care through Medicaid, and we are under the impression that the healthcare authority may have an interest in increasing access to naturopaths in the form of increased prescriptive authority. Mandatory reporting of breast density information to patients. That's Senate Bill 6416. This is another one of those pieces of legislation you may be familiar with and you may have seen before in our publications. This bill is pretty simple. It would require that a radiologist inform a patient in the form of a letter or sort of a cold call, if you will, of their breast density status and an indication to that patient in that letter that they may be at risk of breast cancer. So this bill is problematic for a couple of reasons. One, because a cold call or a lay letter to a patient is likely to result in increased use and panic, quite frankly. So we worked with the other impacted specialties on this particular issue to explain to Senator Rolfes and those other legislators interested in this mandatory reporting that this type of approach is really a cost and use driver, especially if we indicate to a patient they may be at risk of cancer with no proved or proven additional testing to perform on that patient. This is one of those issues that may actually take care of itself in the end, because as science and technology advance, the problem of reporting may become obsolete. There may be additional testing for a patient. What the Medical Association is looking at is we're looking at, again, trying to moderate cost and use drivers. We want to make sure that the care is appropriate, that the notice is appropriate, and that most certainly the treatment is in alignment with accepted practice. Okay, we're going to move into the Healthy Doctors, Healthy Patients section. You probably have heard about the 2-year campaign that the Medical Association is embarking upon to address administrative simplification and physician burnout. So if you're not comfortable yet with HDHP, you should be, but more certainly if you want to think of it in terms of administrative simplification, that works as well. So take a look at this slide. I'm not going to read this slide verbatim because everybody on the call, I presume, can do that for themselves. But let's address a little bit of the problem statement behind these bills and why these bills were successfully passed or addressed. So credentialing. We had heard from our membership that they were having problems with receiving an accepted credentialing application from insurance carriers. We were hearing that some of our members were submitting their credentialing application to an insurance carrier and having to wait up to 8 months to hear a reply from that insurance carrier. There is no requirement in state law for a standardized turnaround time for a carrier to return that application and involve that practitioner in the network. So what our attempt to do was to standardize that turnaround time and process for credentialing. Now, it's important to keep in mind that when we talk about credentialing here, that word can mean a lot of different things to different people. So in this particular instance, we're talking about credentialing from an individual practitioner to an insurance carrier. We are not talking about those hospital or facility-based arrangements that that facility or hospital may already have enforced with an insurance carrier.
Delegated agreements, right? No delegated credentialing, not impacted by this.
Right. So what we ended up doing is we went from a state of law that had no standardized turnaround time or process, and we put one in place. We worked in partnership with insurance industry and other stakeholders and other provider groups to make sure that this bill satisfied their interests and their needs. And here's what we ended up with. 2 things. Number one, a standardized turnaround time. In the first year of implementation, second and third year, we'll see that turnaround time be capped at 90 days, 90 days, and then a 60-day average. So again, carriers will have to return that application to you and accept you into their network should they choose to do so. 90 days, and then a 60-day average turnaround time. The second part of this bill was actually the brainchild of Representative Cody to require use of provider source. So we pushed that component out to 2020, but it would require providers on one end, including physicians, and carriers on the other end of this electronic portal, so that what we're having is both parties on the same end of the electronic portal, so there won't be that mishap with paper applications. And ostensibly, the application itself should be standardized across payers.
So that rather than having to use a different system, a different set of paperwork for each carrier, you go to one stop and you're able to credential with all the carriers in the state.
We're really excited about that particular piece of legislation, as you can tell by our giant thumbs up. So let's move on to medical assistant medication retrieval. Now don't start freaking out. Don't freak out yet. This was actually a clarification, and this is part of what the Medical Association can do to stop a problem before it becomes a problem. So what we saw here is the Pharmacy Commission had a bit of overreach. They were walking into some of our clinics and realizing, oh, okay, a medical assistant is going to the back room to retrieve the medication that the physician asked for. And then Pharmacy Commission put the kibosh and threatened sanctions and said, nope, you are not allowed to use a medical assistant for the purpose of retrieving medication. You are not allowed to use a medical assistant for the purpose of going to the back room and retrieving that medication. So this bill is pretty simple. It simply redefines the term administration to include retrieval of medication. Sounds boring, but it's very important for the operation of practice and workflow. So what we did is essentially avoided a major problem that was being started through the Pharmacy Commission, addressed that in law, and we've got that clarification now, and practices can continue operating with their medical assistants as they have before.
The second and the last two bills on the list here, I want to focus less on the bills themselves and more on the issue. We've been hearing from a lot of you that you are spending more and more time interfacing with benefit managers, be it pharmacy benefit managers, radiological, mental health, you name it, and less time interfacing with your patients, which is obviously a problem. So two bills that were brought forward this year, the last one on the list there passed, pharmacy benefit managers. It pertains directly to pharmacies, less benefits or less impact on broader medicine. The third bill there, benefit managers, House Bill 2445, would have imposed a regulatory structure over all categories of benefit managers, something that I think there is some merit to, something that I would anticipate that the legislature will take up again in future years. In the context of a short session and folks having a lot on their plate, this bill was pretty broad, and it ended up, for the purposes of the legislature, being drawn too broad from the beginning, and it ended up falling by the wayside. But again, the issue will be taken up again in future years.
Okay, we're moving into the topic area we generally call workforce and practice of medicine. It's sort of a hodgepodge here, but you guys will be able to follow along. So let's start off with the Interstate Licensure Compact. This was one I was particularly interested in, and considering the legislature had contemplated it at least in idea form last year and was prepared to handle it in bill form this year, we're very disappointed that this bill has died. What did it do? House Bill 2452 was Medical Commission and Department of Health request legislation that would have allowed Washington to participate in the Interstate Medical Licensure Compact. That means that if you're a physician who wants to practice across state lines or in another state, today you are able to apply to be a practicing physician in a particular state. If you want to practice in all of the states, you would have to submit an application independently to each one of these United States. The Interstate Medical Licensure Compact would make that easy. It would instead be a one-stop shop for you, where you apply for an Interstate Medical Licensure Compact license, and then you would be able to select those states that you have a desire to practice in. You would have to adhere to the laws of that state, and it standardizes discipline and licensure, across state lines. There were significant questions from the legislature, and I will clue you guys in on why this bill died. It died sort of under the weight of these questions. Number one, central to the nature of a compact, there was some concern among members of both the House Healthcare Committee and Senate Healthcare Committee that this bill essentially outsources a rulemaking function to the commission that would implement the compact. So again, outsourcing basically a state sovereignty concept, that we would hand that rulemaking authority for the operations of the compact to another entity that is not Washington State. Outsourcing that rulemaking function was a concern of some conservative members, so the bill faced some opposition in that regard. The last concern on the bill, and the one that really crushed the bill, was a concern about, you guessed it, webcam abortions. So you may have heard that concept of webcam abortions bleed into the telemedicine sphere in earlier years. because the Interstate Licensure Compact does impact telemedicine to some degree in that it would make it easier for a physician to practice across state lines, that webcam abortion concept bled into the Interstate Licensure Compact bill in the 11th hour, and any sort of concern raised like that at the 11th hour pretty much ensures the bill's timely death. Those concerns were raised by the Family Policy Institute. Okay, so let's move on to one with a little bit better news. We're very excited for Senator Becker's leadership on Senate Bill 6519. You've heard in the past our push for telemedicine reimbursement, and you remember that last year we passed legislation that was an agreed upon legislation to provide for reimbursement for services delivered via telemedicine. This bill takes it a step further and does two things. Number one, it would provide for reimbursement for services delivered via telemedicine to the patient in home. So it expands the definition of that originating site, and in essence, if you're looking to practice telemedicine to a patient in their home, you, according to the contract you arrive at with the carrier, can bill for that service and be reimbursed. The second component is still to be determined. The legislation contemplates a telemedicine or telehealth collaborative housed within the University of Washington. We're really excited to work in partnership with the University of Washington on their telemedicine programming, and essentially this would be the best place to have that collaborative. The collaborative would contemplate how to advance telemedicine appropriately in Washington State and has a broad group of stakeholders who would participate in that collaborative. Why is the collaborative still up in the air? Simply because it would require funding. The University of Washington has indicated that they can host the collaborative, but it will be scaled based on the amount of money they receive. So until we see a final budget with money to support that collaborative, the collaborative component of that legislation is still up in the air.
And this is a fairly nominal amount of money, I'd note. You know, we're not talking about millions, you know, for I think $150,000-ish that the University of Washington feels that the collaborative could be run well.
Lastly, the prescription monitoring program. I do encourage you to email us about this bill. If you actually pulled up House Bill 2730, it might look a little bit confusing, but it's actually pretty simple. We're really thankful that we got to work with the Hospital Association on this priority legislation, and we're pleased with the results. In essence, this would allow for bulk access to the PMP for hospitals and provider groups of 5 or more physicians. So what does that mean? Today, if you're a physician, you can go onto the PMP website, enter your information, and have access as a prescriber to the PMP. This bulk access bill, House Bill 2730, would allow essentially one person to interface with the PMP at that hospital or that facility and be able to have their physicians and staff have access to the PMP. It does also, this legislation does expand access to the PMP to those who prescribe legend drugs, not just some of the more scary drugs for which the PMP was designed for. Again, for provider groups 5 or more, and you as an individual can still register with the PMP. It does not change that book of business whatsoever, but it does increase access to the PMP so that we can make sure we're doing our part to address the opioid epidemic.
So moving into liability and business practice, I'm going to speak very briefly to these first 2 bills here, largely because they continue rather than change state law. Senate Bill 6156 has to do with Medicaid fraud and key TAM. This is the ability of private attorneys to pursue actions in instances of Medicaid fraud. A bill that was passed several years ago, it had a sunset date, meaning that if it weren't continued, the bill would expire. There was an interest among the Attorney General's office and some legislators to continue this indefinitely. What we asked is that a sunset date be put on the key TAM provision again so that we can come back in 2023 and revisit, make sure that our docs aren't being hit by these Medicaid fraud suits. To date, they are not. The second bill there, blinded provider compensation agreements, just ensures that the agreements that you sign with insurance carriers are not subject to public disclosure. They are filed with the OIC and they are kept confidential.
You might find it a bit interesting, a little bit of inside baseball on the blinded provider compensation agreements. We did have testimony from the newspapers seeking from a transparency angle that that information be unblinded. You can tell that from our position we were not favorable to that request, but that's what we get to deal with when we have legislation that we think is an easy win, and we end up getting having interesting conversations throughout the legislative session in an attempt to keep our bills on the straight and narrow. So very lastly, what you're seeing here is prohibiting or restricting the use of non-competition or non-solicitation clauses. So as you should well know, the Medical Association, we do not have a position on non-compete clauses. There's really a range of perspectives on what to do with non-compete clauses. You can see the bill numbers down below, House Bill 2406 and House Bill 2931. One of them, Representative Manueler's bill, was an attempt really to address non-competes for those low-wage or low-skill workers. Those folks who are working, for example, at a Jimmy John's, who arguably might not need to have a non-competition or non-solicitation clause enforced. House Bill 2931 was quite a bit broader and problematic for a few reasons, the most notable being the courts are those who currently decide which non-competes are unreasonable. So setting those standards in statute is problematic, and this particular bill would have impacted those non-competes on physicians. Again, the Washington State Medical Association, we have no position on them, but we do know that our membership has interest in these pieces of legislation, so we wanted to make sure to include it. We are going to take a pause here and jump into some public and community health bills. We want to make sure we leave time for questions at the end, so you can expect that we will move through these bills rather quickly at this point.
The first one on this list, a good little bill, as people say in Olympia, maternal mortality review. So jump in the time machine, people. Back in 2008, 2009, the Department of Health convened a group of folks who would get together and examine the circumstances under which women died in childbirth with a goal of decreasing women dying in childbirth, improving public health and improving outcomes. That process went away during the recession. We had a resolution passed at the House of Delegates in 2011 that said we need to get this back online and we need to formalize it in state law. That's what this bill attempts to do. Very excited that this bill sailed through the Senate and the House. The last piece is funding. It's been funded consistently in the Senate budget. It has not been funded in the House budget. We're very hopeful that the final budget will include funding for a maternal mortality review panel, which would make the bill go into effect. If that funding's not in there, this bill is voided. It's null and void.
Okay, let's move on to that second bullet. This can be lovingly referred to as our Age 21 Plus bill. The Washington State Medical Association has policy on the books to support raising or bumping up that tobacco or smoking access age from 18 to 21. You can see there that that bill is NTIB, necessary to implement the budget. I would venture to say that it's dead. This bill was one of the Washington State Medical Association's lobby day priorities, again, to bump up that access purchase rate for tobacco and vapor products from 18 to 21. The bill was actually pushed by the state's attorneys general and by a broad coalition of patient rights groups, patient groups, consumer groups, etc. We were there leading the charge, and we're happy to make that our lobby day priority. Unfortunately, that bill is likely dead. I will not spend a lot of time on this third bullet concerning vapor products. These two pieces of legislation that you can see there from Senator Danmeyer and Representative Paulette are in flux at the moment. They as well are necessary to implement the budget. The Washington State Medical Association's interest is from the sort of lowest level of regulating these products, advertising to children, marketing to children, all the way to somehow limiting access and increasing the regulatory structure around these products. We've taken a very broad approach and worked closely with our partners in the public health community and other advocates on the issue as these bills have moved forward.
And I think, you know, the reason that they're both NTIB is that they both have an impact on revenue. The last one there, vapor products, would increase revenues to the state, generally speaking, making it more attractive for budget writers who can count on that revenue to use for other areas of policy. And the reason that the 21 bill didn't pass, I think there's a lot of pretty broad support for the concept, but it costs money. If people aren't, if those 18, 19, 20-year-olds aren't smoking, which is a good thing, they also aren't buying cigarettes, which from the state revenue standpoint would have been a fairly substantial hit, and budget writers felt that it was too far of a reach given the current budget. So moving on to the first bill here, pharmacist prescribing. This bill started off very aggressive. It would have allowed pharmacists to prescribe birth control to patients without having them seen a physician. We worked with the prime sponsor of the bill, Representative Melanie Stambaugh from the Puyallup area, and tried to keep a focus on increasing access to contraception, but without expanding scope of practice for pharmacists. What the bill became was pretty simple. It's a pretty small little bill that just raises awareness that, folks, there are pharmacies who have collaborative drug therapy agreements in place with physicians where patients can go in and be dispensed contraception directly.
Okay, and before we move into a bit of an election summary, these last two bullets here, these bills are, you can see NTIB, necessary to implement the budget. The Reduced Distracted Driving Incidents legislation, House Bill 2574. I'd be glad to talk with you more offline about the history of that bill. In essence, the law to date is fairly narrowly tailored, such that it's difficult to land a conviction might not be the right word, but to land a sort of claim against drivers who are texting and driving. Right now, the law says you can be sanctioned for texting and driving, but it doesn't really expand to any sort of communication with a device in hand while driving. So again, Washington State Medical Association, we have policy to reduce distracted driving incidents and would work with our advocates and counterparts on this legislation. For example, family physicians, pediatricians, etc. Similarly, with the last bullet, increasing oil transportation safety, there was a resolution passed within the Washington State Medical Association in 2015 to support efforts to minimize deleterious health effects related to oil and coal transportation in Washington. This bill as well has not made it through the process yet, and if you have any further questions on those, please do hit us up offline.
I'm glad Katie took that bill because I don't think I could have pronounced deleterious. Very, very impressive.
Thank you. Thank you, Sean. Thank you.
All right, the last note here. It's an election year in case you don't have a television and haven't seen the daily or weekly presidential debates. That had an impact on the campaigns of 2016, obviously, but it also had an impact on the 2016 legislative session. We saw a lot of bills fall by the wayside, a lot of bills not even considered because they had a controversial component and legislators didn't want to vote on those bills in advance of the looming campaign. So a lot on the table for this year. You've got the obvious one, the presidential campaign that I know everyone is following. The state's congressional delegation, all of the members of the House of Representatives will be up, all 10. It's not likely that any of those would switch parties per se, but there is a contest to watch in the Seattle area. As you know, Representative Jim McDermott is retiring. There's a number of very qualified Democrats who are running for that seat, so that's one to watch. Statewide elected officials, we're seeing Jay Inslee is up for re-election, facing a Republican challenger. Also keep an eye on, in that race, the Office of the Superintendent of Public Instruction, OSPI Chief Randy Dorn has indicated he may jump in, which would change the dynamic there. You've got the state Senate and the state House of Representatives, both controlled by very narrow margins right now. The state Senate narrowly by Republicans, the House of Representatives narrowly by Democrats. There's going to be a lot of seats in play and a lot of folks who are very anxious to get out of Olympia, get back home and start campaigning in advance of the election. The last one there I'll note, judicial races. This is something that the Washington State Medical Association has long had an eye on. We've not seen a lot of progress in making a more balanced judicial system in Washington State, particularly the Supreme Court level. There's a renewed interest in that, a renewed effort around that, and we're hopeful that we'll see some viable judicial candidates this year. The last couple of notes there, the Vote Tracker and Diamond Club. We rolled out a WAMPAC Diamond Club in 2015 with the idea of invigorating the Medical Association's election activities. We do feel we've got a strong presence on the election side of things. However, the size of our political, our PAC lags behind a lot of our counterparts like the hospitals, the dentists and such. So So we're trying to build that pack up to make sure that we're a force not only in our legislative lobbying, but also on the campaign side of things. You'll be receiving this summer, if you are a WSMA member, a vote tracker. We went through and we highlighted all the very top priority bills. And we let legislators know before they came for a vote, you know, we're watching this one. We really need your vote on this one. We kept track of those, and we'll send everybody out a vote tracker to let you all know how your legislators voted on the issues that are most important to you. Lastly, I will note, we're going to be spending an inordinate amount of time this summer interviewing all these candidates for office, as well as participating in and hosting fundraisers. If you've got a candidate, if you've got a legislator in your district that you are particularly supportive of, and you want to get together with them, you want to maybe host a fundraiser, those things are difficult. They're candidly a pain in the butt. We would be glad to be of assistance to you in any way we can in hosting a fundraiser. And we will also be holding candidate interviews, and we would welcome you to join in those. We will let folks know when there's going to be opportunities to participate.
Sean's being very humble. Sean spearheads our PAC activities, again, our political action campaign activities. So any questions you've got, please do direct them to Sean. He eats this stuff up. Let me flip the slide to the contact slide. So in case you guys have any questions outside of this presentation, we'd love to hear about them. I'm going to turn the attention now to the questions and answer sections, recognizing that we've got roughly 10 minutes to answer those questions. I do see one question that is quite long, and we may have to take that offline, but let's start up at the top. We do have a question. What work can we do this summer and fall, both with electing new House and Senate members and meeting with incumbents to work on issues in the fall? I'll let Sean field most of that, but I would also note that if you have a specialty society or a local county medical society and you'd like us to coach you or your county medical society or specialty society on how you can get more involved in elections and tailor that specifically to your group, we'd love to do that. If you're also coming from a large group setting or a clinic setting, we'd love to help you in that regard as well. Sean had mentioned earlier interviews, WAMPAC, Diamond Club, and contacting your legislator in district. But I wondered if Sean has anything else to add.
Yeah, it's a great question, and this is a really opportune time to be working on this. State legislators, generally speaking, are easier to interface with, and I think a lot of people realize they're always eager to meet their constituents, and due to the fact that they don't have a huge number of them, they're able to do so generally. But they're particularly interested to meet their constituents during a campaign year, which we are in. So the first step is trying. The first step is reaching out to them, letting them know that you'd like to get to know them better. You have some issues that are important to you that you'd like to talk about. The easiest way is probably over a cup of coffee somewhere. But what I really suggest, where and when possible, is that you have those candidates and you bring them into your place of business, your practice, let them see you at work, let them see what it is you do, the good work that you do, as well as some of the difficulties that you're having with, whatever issue it may be, and bring them in to get a first-person experience is something that I think can really help build those relationships. Those are then relationships that during the next legislative session, when you see something come up that you like or you don't like, you're going to have a direct line to that legislator to be able to affect change.
Now, people, I know you probably are glazing over at this point in the presentation, and I need you to not to, because what Sean just said really is a game changer for the Medical Association going into next legislative session, and can be a game changer for your relationship with a local elected. And it's not as hard as it sounds. So don't give me the it's hard. We want to do what we can to help support you in getting an elected person into your place of work specifically. So let's move on to a couple of the other questions. We have a logistical question. May I get a copy of the presentation to make sure I don't miss anything in my notes? Absolutely not. Absolutely not. No, we're just joking, of course. We'll send this out in follow-up. Trevor Justin, actually, who heads up our outreach and advocacy program here at the Washington State Medical Association, will follow up over email with a copy of these slides. And I do also believe that we will be putting a copy of this webinar up online on our website so that you can re-watch this. I figure you'll be watching this instead of House of Cards, though I hope you've already completed your season of House of Cards.
So the next question we see, and this is a good one too, what happens with the bills that died this year? Will those efforts start over and need new sponsors? So we talked earlier about the bills that died in 2015, 2-year biennial cycle. So they automatically were reintroduced in 2016. So what happens to all these bills now? The ones from 2015 that still haven't passed and the bills from 2016 that have not passed, they're dead. They're dead. And there will need to be a new effort next year. You'll need a new sponsor. They will be reintroduced. There'll be a new bill number and a new process that starts all over.
You might be wondering, Debbie, who asked that question, you might also be wondering, we mentioned those bills that were vetoed at the a couple of weeks ago. Those bills are technically dead at the moment, so as Sean said, they would need to be reintroduced next year if we're going to see them again in the following year. The legislature right now is actually contemplating a couple of things with regard to those 27 bills that were vetoed. In order to override a governor's veto, in order to override and undo a governor's veto, it would require a 2/3 vote on the floor of both chambers. So in this case, the Senate could take up these 27 bills or however many they saw fit and have a 2/3 vote to override the governor's veto. It would also require coordination with the House, so the House would have to perform that same 2/3 vote override. It's not just a mechanical question that the legislature has to contemplate there, but actually a political one. Debating which chamber would actually make that move could have some implications on the relationships between Democrats and Republicans as it relates to the Democratic governor. What we will see in all likelihood, if these bills, if the vetoes are not 2/3 override, the Senate or the House will unlikely to reintroduce in this special session, but and then rerun a bill simply because there's no time and it would be a risky procedure to do that. We would again see these bills reintroduced in the following year. So there is a very long question here about the prescription monitoring program, and simply because of its length, author, we will follow up with you separately on this particular question. We'll take a second to review it, but in the meantime, we'll move on to the last question. The question is, we know that the Interstate Licensure Compact legislation died this year. Do we know if there was any commitment to revisit this in the future?
Believe it.
That's the answer. It's important to us. It's important to several other associations. It's important to Washington State. We'll see it again.
It's very unfortunate that this did not pass this year. I will say, though, in a short legislative session, again, anything that's controversial, anything that's complicated tends to fall by the wayside. This was, frankly, a fairly big lift in a short legislative session. It would have been great to have gotten it through this year. We will be circling back with legislators, and we will get this bill, hopefully, next year.
And actually, Sean leaves us on a good note there. If you have a particular interest in any of these pieces of legislation, your elected officials want to know about that. So you don't just have to pull them into your office or show up at a coffee shop with nothing to talk about. Feel free to bring this slide deck and press them on each of these pieces of legislation. Number one, you probably already know more about it than they do. And number two, they're desperate to talk to you about what you're interested in, and vice versa, I should hope. So again, if we can do anything to help you connect with your legislator and connect you with the WAMPAC Diamond Club or answer any further questions, we welcome the opportunity to do so. Again, we'll follow up with the longer question that we see here in the webinar panel, but we're really grateful for the opportunities that you gave us to present to you. You can see both Sean's and my contact information to the left of this last slide. And we love the work we do down here. We also have a regulatory arm, and any questions, shoot them our way. Thanks a lot, guys.
Thank you all for participating. This is the end of our presentation. Hope you guys have a great afternoon. Thank you.